As you know, Dr. Boris Malugin is a well-known person. It's actually this thing to introduce him to the August audience. He's actually the face of the entire Soviet Union, I would say, the Russia, and for very.
Your internet is not coming properly.
Boris Malugin, are you there? Boris?
Yes. You went off for a while.
I'm here. Thank you.
Yes, thank you very much for being here and delivering the keynote address for us.
Okay, so
Could I
please, play my presentation. I apologize because my internet is weak, so I decided to
who has got
a
a
recorded presentation, which
Himai has got.
Yeah, I think
Mike?
that will be.
Dear colleagues,
Yes.
it's my great pleasure to discuss with you today different techniques that I used for patients with lens subluxations and ectopias. The main surgical goals in these patients are to preserve capsular bag for IOL fixation and to provide stable IOL position in the long term postoperatively. There are several devices that can help us to stabilize the capsular bag during surgery, such as capsular hooks. There are many useful devices that can be sutured to the sclera and provide long-term capsular bag stabilization. Capsular tension rings of various types are among the most popular. They can be utilized in the variety of clinical conditions from relatively mild to very severe zonular instability. Malugin modified CTR is having an eyelet that is moved to the very tip of the device. That make it much easier to implant into the eye with the help of the injector. Over the years, my preferred suture was 90 polypropylene. However, quite recently, Gore-Tex was also introduced into my clinical practice. With polypropylene, having both ends of one suture attached to the same needle, forming the loop, it is quite easy to use the co-hitch type of suture attachment to the eyelet of the CTR. After exiting the eye, the suture is fixed to the sclera with zigzag technique proposed by Peter Schurman. L-shaped incision of the conjunctiva is made, and the needle is passed parallel to the limbus 4 or 5 times. Here is the clinical case of the patient having Marfan Syndrome. As shown here, capsulotomy is initiated with their microforceps. Following that, the capsular bag was stabilized with the special capsular hooks introduced through the opening in the anterior capsule, as shown here. And this is a very useful device because the tip of the capsular hooks rests at the equator of the capsular bag and does not cause a lot of stress on the edge of the anterior capsular axis. Following by aspiration of the relatively soft cortical material, CTR is introduced into the capsular bag, and we can see that suture is attached to the eyelet of the CTR, and after rotation of the fixation element into the proper position, we release the capsular hooks, we reposition the fixation element on top of the anterior capsule, as shown here, and that passes the needle through the ciliary sulcus outside of the eye, and then aspirating the residual cortical material from the capsular bag, implanting IOL in the capsular bag, and positioning it the way that the haptics of the lens are not interfering with the position of the fixation element. Certain anatomical considerations should be kept in mind when utilizing the Z suture. First, relatively wide scleral exposure is needed. And second, there is not enough space for the suture when the needle exits close to the rectus muscle. Over the years, This technique showed us the stability of the implant and the reliability of the clinical results. And you can see with the blue arrows the location of the CTR in the capsular bag and also the intrascleral path of the suture. We performed this technique with a great success. However, 2 years ago, the patient came back to us after 5 years following implantation of the CTR and suturing the sclera. And you can see here that the IOL is dislocated. The suture is located under the conjunctiva, and during the surgical procedure, when we inspected the area of the suture, we observed that there is a suture break that happened over these years. This patient needed refixation of the capsular bag with another suture, and this problem was resolved. We use scanning electronic microscopy to examine the suture, and we've seen a significant amount of fire degradation of this 9-0 polypropylene material, as shown here. And also, we observed the thinning of the tips of the suture directly attached to the eyelet of the CTR. Starting from the case, we finished using 9-0 polypropylene, and this is current technique, which is illustrated by this video fragment. As shown here, there was a significant lens subluxation. Now, phaco emulsification is being performed with the help of the capsular hooks that are supporting the capsular bag, and you can see here that the lens is quite stable. Now I'm injecting modified CTR inside the capsular bag, while there is some cortical material still present, with the reason being to avoid aspiration of the equator of the capsular bag, which is not uncommon in that kind of surgery. In spite of the capsular hooks that are in place, there is still a gap in between them where that issue may happen. I decided to attach the cortex to the eyelet of the CTR without doing it outside of the eye. Sometimes it's much more helpful to do it that way. For that purpose, I'm using two 25 gauge forceps. Bent 25 gauge needle will be used to introduce the suture through the ciliary sulcus and go out of the eye through the sclera. As shown here, this is one tip of that suture that is passed through the sclera, and I will be using the same needle to pass the second portion of that suture and again go out from the eye in the area adjacent to the first exit. The ends of the suture are trimmed, and it's time to implant the IOL into the capsular bag because the later is stabilized with the CTR fixed to the sclera. And this is a hydrophobic acrylic IOL that goes into the capsular bag that unfolds quite slowly in the controlled fashion. So I will be able to guide the haptic into the capsular bag, and then, which is very important step, station of the knot inside the sclera. My preferred technique in patients with significant zonular dialysis and lens subluxation is based on capsular bag stabilization with the modified CTR. I do think that Vortex is the best current option for CTR suturing, and this technique is being a viable alternative to the iris floor, scleral or iris sutured IOLs, and even flanged IOL CTR techniques. And I thank you very much for your kind attention.
Thank you, Boris, for the wonderful, very innovative method. Every time you learn new tips, and you are simply amazing and incredible stuff from whatever we learned, and we are thankful to you for coming to the AOS and presenting. Every time you are there in the AOS conference, we see you the conferences, more so in AOS conferences also. Thank you very much, sir. So if we go on to the course. The course is on IOL fixation techniques, what we are going to do now. And we have got an excellent faculty. I'm going to share my screen now. And able to see my screen? Able to see my screen?
Yes, sir, it's visible. Visible.
Audio.
Please tell, yeah.
Internet is
Yes,
unstable.
we have got an excellent faculty, and we are going to talk to on the various ways about IOL fixation, whether it's a glued IOL or a sutured scleral fixation or an iris claw lens and dropped IOLs also. We have an excellent faculty. I am Dr. Mohan Rajan, and along with me is Dr. Amar Agarwal. He doesn't require any introduction. He is the supreme, I would say, as far as ophthalmology in this part of the world is concerned. And then we have Dr. Sujata, who's going to talk to us on sutured scleral fixation lenses. And then we have Manoj Khatri on dropped IOLs and Nivian on the lens as well. So let's go through this. First, the PCR 10 commandments. As you all know, early recognition combined with advanced instrumentation enabled effective management of posterior capsule rupture during phacoemulsification. Any stage, the PC rupture can occur during hydrodissection, nucleus removal, cortex removal, posterior capsule vacuuming during IOL implantation. So, if you don't manage the PCR properly, then you can end up in problems like retinal detachment, cystoid macular edema, and very rarely, not very rare, very commonly, is because the incidence of endophthalmitis can go up in PCR patients with vitreous loss as well, as high as 4 to 5 times. What are the early signs of PCR? Sudden deepening of the anterior chamber, loss of lens fallibility, lens tilt or deepening of the posterior chamber as well. Let's go through the 10 commandments very quickly. Number 1, okay, anticipate PCR in traumatic cataract, cataract post-vitrectomy. Nowadays, a lot of injections also, anti-VEGF, posterior polar cataract, dense brown cataract, pseudo-exfoliation, small pupils, and all these are what you call red flag signs as far as PCR is, and have a plan A, plan B, and plan C for these patients. Look at this particular video. You can see here there is a sudden deepening of not only the anterior chamber, but also the posterior chamber. If sudden deepening occurs, then there is an underlying disaster in the form of a PCR. So this should give us an early indication. So you should be able to recognize this PCR much early. Number 3 is loss of lens fallibility. Why the lens fallibility is, in fact, despite the fact that you keep increasing your aspiration flow rate in a peristaltic machine or a vacuum in a venturi system, the lens does not come into the phaco port, that is, the nucleus does not come into the port as much as you anticipate, or as much as you expect. The sudden loss of lens fallibility should give you an indication there's an underlying disaster like a PC rupture. PC rupture during hydrodissection and sudden contraction of pupil, that is called the pupil snatch sign, which has been described by Ron Yu. You can see here, as I'm doing the hydrodissection, the nucleus. You can see that particular thing, and wherein the hydrodissection, if you don't decompress the nucleus after every wave of hydrodissection, this is what will happen. You can see that. Look at this anterior capsule very carefully. When I do the hydrodissection, you can see how it's opening up, because there is an increased pressure between the nucleus and the posterior capsule, and the anterior capsule opens up, and sometimes the pressure can go and produce what is called an acute capsular blowout syndrome. Avoid hydrodissection, posterior polar cataract, traumatic cataract, previous vitreoretinal surgery. Be careful about that. Avoid removal of instruments is very important. If it's a small PC tear, you can convert that into a posterior capsular excess, because the posterior capsular excess definitely has got a better stability and strength, and you can go ahead and put the lens in the bag without any problem. Large PC tear as you know, the bimanual vitrectomy is because vitreous acts like a slinky. You need to have a separate infusion and aspiration and cutting or AC maintenance. So separate the infusion or the irrigation from the aspiration or the irrigation, the cutter as well. So this is a coaxial thing, the animation which has been described by Bobby Asha. When you have a coaxial, when you have PC tear and you have coaxial irrigation aspiration, the PC tear starts enlarging and more vitreous starts coming into the anterior chamber. And what is the initial PC tear of about 2 millimeter can enlarge to about 6 millimeter, and you lose. Not only that, there can be traction on the macula, traction on the vitreous base, and all these problems can occur. Whereas if you have a bimanual one, which is one of the most important thing, is if you have a bimanual, wherein you have a separate anterior chamber maintainer and a separate irrigation or a separate cutter, then it prevents the hydration of the vitreous and also prevents the enlargement of the break as well. High cutting rate, 3,000 to 4,000. Nowadays, it's available in all the machines. And number 4 is do not pull out. When you have a PC tear, most important thing is do not pull out of the eye. If you pull out of the eye, what will happen is the PC tear will start enlarging. You can see here in this particular case, the PC, you get a PC tear, you become jittery and come out of the eye. If you pull out of the eye, you can see that the PC tear starts enlarging and more vitreous will start coming into the anterior chamber, and even the nucleus started descending into the vitreous cavity as well. Number 5 and 6, when you have a PC tear, always make sure that you introduce preferably something like a viscoat. Because the viscoat will go and plug the PC tear. That's very, very important. The viscoat will go and plug the PC tear. You can see here I'm trying to remove the last nucleus piece because of the post-occlusion surge. This happened long time back. I'm having a PC tear there, and I'm injecting viscoat. I'm not losing my calm here. I'm injecting viscoat. What will happen is the viscoat will go and plug the and slowly withdraw the phaco handpiece from the eye. So this is a stabilization of the anterior chamber is very important. They immediately create a right side port and go bimanual, which we always do when you are in coaxial. Always go bimanual. Number 7. Techniques. Use the right side port because normally you are in the coaxial irrigation. Some people do the bimanual irrigation aspiration, but bimanual technique is always important. Wherein you cut you separate the irrigation from the aspiration or the irrigation from the cutter. Keep the irrigation always there and change the cutter and the aspiration port. So the bimanual is very, very important. Number 8 is central anterior colorless substance. You know the presence or absence of vitreous unless you put preservative-free tricot, dilute it 1:3, and you can do that preservative-free tricot, and we can delineate the vitreous. Always remove the vitreous first and then remove the cortex. Don't try to remove the cortex in the presence of vitreous in the anterior chamber, because every time you remove the cortex of the epinucleus, in the presence of vitreous, you can produce traction on the vitreous base. Just to show you a posterior polar cataract, and I'm doing that, and you can see here, as I'm removing the epinucleus, there is a large PC tear, which is very, very typical of this posterior polar cataract. I inject aspiration. Once I know that the vitreous is there, you may put tricot, go ahead. Yes. And go ahead and do the anterior vitrectomy as well. Consider again with the PPC and trying to move
Mohan, your audio is a problem.
Sudden deepening.
मोहन सर आप अपना वीडियो ऑफ कर लीजिए.
Internet is unstable, Mohan. You're not.
Mohan, your audio is not clear at all.
Not able to hear?
No, it is
वीडियो
just
ऑफ कर
breaking.
लीजिए. वीडियो.
Video is also slowing down. It's like unstable. Yeah, you're stuck in one place. Shall we, Amar, what do you think we should do?
Exit over.
Mohan? Not
Yeah.
able- it's not.
Nobody can hear you, Mohan.
This thing is not good. Do you want to come down and present? You can present from my Mohan. You want to come down and present?
I'm just trying to Are you able to see my screen?
Yeah,
Sir,
no, screen.
Sir, yeah,
screen,
sorry
we're
to
just your face.
intervene. Dr. Mohan, there's some issue with the technical issue with your on your end. So what do we
From my
suggest?
side.
As doctor is inviting you to her area or her office, you can definitely go there and do that. Meanwhile, we'll take another presentation. So
I think so. Okay, we'll do that.
We'll go to
Okay,
Amar's
sir?
presentation. Amar,
My
Okay.
audio is
I'll-
clear now. My audio is clear now.
yeah, now it's clear, but it's not syncing with your video. Video is going very slow.
We'll go on.
Mohan, it comes and goes, Mohan, your audio. I would suggest go to Sujata's computer and use her laptop.
No problem. No problem. We'll go on to the next presentation. Dr. Amar Agarwal, as you know, doesn't require any introduction. And he's the master of the glued IOL, SFT, and so many other innovations in cataract surgery and so many other innovations he's got. And he's the top ophthalmologist, the most sought after ophthalmologist in the entire world. And always, Amar, it's a pleasure to have you in our course. And he's going to talk to us on glued IOL tips and tricks.
Thank you very much, Mohan. I think basically what Mohan and Sujata have done overall is something phenomenal, to be honest to you. The centers they have created are no doubt fantastic, but the work they are doing for so many people in ophthalmology is also just excellent. This course which they do is such a famous course, not only in AIOS, but in American Academy, in ASCRS, and in ESCRS. And to be honest, it's a pleasure for being there, and Boris and others like Nivian and Manoj Khatri also, such a pleasure to seeing all of you there. So let's start this presentation. I thought I'll show you this case. And this is why I want to tell you, look at this. This is the problem in suturing. Someone has sutured this lens, and subsequently years later or sometime later, this is what happened. The lens starts subluxating. And this is where the IOL fixation techniques come into play here. Now we have taken the case back. You can notice I made my two scleral flaps. I'm making my sclerotomy. Now you'll notice there is an endocapsular ring inside the eye also. So I'm doing my vitrectomy, trying to clear it up. And as I'm doing that, look at that. The whole capsular bag complex is sinking. Now watch carefully. There is a segment also there. So the surgeon had actually done a great job, because you can see he had fixed it with an endocapsular ring. He's also fixed it with an Ahmed segment there. And you can see the suture also there. The problem is these sutures erode with time. And that's why Boris was talking about using the Gore-Tex. But here you can see I'm trying to take off that suture before it goes down into the vitreous cavity. There you can see that coming out. Now the problem is to remove this segment. I'm trying to remove this with the handshake technique. So I'll have to extend the incision a little bit on one side and pull it out, because you can see there is a loop of that segment there. And I have to be very careful when I remove this loop there. Here you can see the segment coming out. But the reason I've selected this particular case in this course was to show you the problems of this IOL fixation. Now, once that's done, remember my lens capsular bag entire is still inside the eye. So I have to just do a vitrectomy there. And once I do my vitrectomy, I will use the extrusion cannula assisted technique, which Ashwin has taught me on trying to bring this bag out. Once it is there in the anterior vitreous, I'm catching either the haptic or the endocapsular ring, because you'll notice the blue portion is the haptic, but you can see the white portion, the transparent portion, is the endocapsular ring. Again, I repeat, the surgeon, whoever had done the surgery, has actually done a great job, because they have fixed it with an endocapsular ring and with the Ahmed segment. The pupil is small. I brought out one haptic, as you can see there, but I want to dilate this pupil. So I'm using these iris hooks at this stage. You can use the Boris's ring there, but in cases without capsule, it's a bit tricky. So here you can see I'm now removing all this capsular bag complex. At the same time, I'm holding on to the haptic so that I don't want that lens going down any further than already once it had gone down. Now you can see I'm trying to remove this endocapsular ring, because that's another headache which you will face. You need to remove that endocapsular ring also. That's my second haptic there. I'm doing the handshake technique, moving the hand from one hand to the other, trying to catch the basic endocapsular ring and also the haptic. Now you see both haptics have been externalized. I'm going to use this plug. This is a great trick by Steve Safran, Roger Steinhardt, and George Baiko. George Baiko started this whole thing of using this plug. So you can use anything like an IV set. You can just cut a small portion of the IV set, put it on a 26 gauge needle and bring it onto the haptic there. Once it's there, this haptic will not go back into the vitreous cavity. Now, once my lens is stable there, my next step is to take out the endocapsular ring. Now, remember when you remove this endocapsular ring, catch the haptic, because if you catch it somewhere in the middle, what will happen is the endocapsular ring will just break, and I want to bring it out en bloc in one piece. Here you can see I'm pulling out that endocapsular ring and taking it all off. After some time, all this capsular remnants I'll just knock off there with a vitrectomy probe and clear it all off. Once that's done and the endocapsular ring also removed, my next step is to refixate the other haptic which is lying inside the anterior vitreous space there. And that's quite easy now because the first haptic is already stabilized with the plug there. Here you can see the endocapsular ring come out there. I just had to catch this haptic and externalize the haptic there. Once both haptics are out, the next step is very simple. All we need to do is tuck the haptics in. Watch carefully. See how much of haptic is externalized. It's a lot. You need that much of haptic externalized. Otherwise, you will be in trouble again post-operatively. I'm very particular that I come more anteriorly so that more haptic is externalized. Take a 26 gauge needle, create the tunnel, Chariot's pockets, and then tuck the haptics inside. Once both haptics are in, my next step is to take out my iris hooks. At this stage, if you have an optic capture, please do a single pass photoreopuplasty. In this case, there is no optic capture. All I need to do is apply the glue and seal everything down and complete this case. Now, I wanted to show you one more thing as we have some more time there, because I have shown the glued IOL, but I thought we'll also show you this modification of the Yamanese, which we have published. It is the riveting handshake Yamane technique. I don't do, frankly, the Yamane for the simple reason we have assessed both Yamane and the glued IOL, and the stability is much more in the glued IOL because there is no tilt. But those who are still doing Yamane because it's comparatively easy, take 2 millimeters behind and 2 millimeters horizontally, as you can see here. But in this riveting technique, you see we are taking this needle inside, locking it straight into the leading haptic in the animation, as you see there. Once the haptic out, catch it. Now watch, this is the basic Yamane technique. But what we are doing is we are adding the riveting. That means you're taking a needle holder and pressing it, just like how Dr. Musa from Japan showed us for the rivet technique for the iris suture. We thought we'll do it for this also. Here you can see this is the Yamane technique. And what we're going to do now is we're going to compress this. Here you can see that's happening, and that's the compressing. This gives you a broader base. So the chances of it falling down or getting dislodged are not there. The next step is to do the handshake technique, because with the handshake technique, you are in full control, bringing this haptic out, doing the Yamane, now doing the riveting so that the case gets completed. And that's what I thought I'll show you on this particular riveting handshake technique. I thought I'll also show you the actual surgery of the same thing which I showed you just on animation. And you'll see here 2 millimeters behind. But again, I'm repeating it. We do the glued IOL by and large. This was the time when we were working on the Yamane to see how happy we can be with it. But we have gone back to the glued IOL because we have seen the IOL tilt is a big issue in Yamane compared to the glued IOL technique. We also published our results of a 12-year study of the glued IOL in the JCRS recently, which shows extremely very, very less tilt there. Here you can see the Yamane being done there. Now you will see I'll just take the needle holder and broaden the base there. In other words, rivet it behind. So once you have the first haptic there, I'm now doing the second one. I'm doing the handshake technique, which helps me guide the needle and the haptic bang on track so that they are both in line with each other. Once the second haptic is out, again you will see me doing the Yamane there and then doing the riveting of the technique there. This by and large completes my presentation, and I'd like to thank Mohan and Sujata once again for asking me and inviting me for this lovely course of yours. Thank you very much.
Thank
Mohan
you,
and
Amar.
Sujata.
I think as usual, you are the best. And the amazing videos, the amazing animation, and the way you explain things. And not only the glued IOL, we have also found out that the M&A, the only problem with the M&A I find that is that you're able to hear me.
Yes.
Okay. Is that because you do not know how much of haptic is going and sitting there. Okay. Inside, it's a blind technique. Whereas glued IOL, you can tuck it on one side, you can pull it on one side, you can actually see how much of activity is going and
can center it exactly where you want it.
Yes, exactly. And that is the reason probably the pseudophacotunosis is much less, very minimal in a glued IOL. Even in our hands, the glued IOL technique. But this particular innovation of M&A technique wherein you compress that head is definitely better because it's got a broader base and it's less likely to slip through the scleral.
Correct.
So fantastic innovation, Amar, and very tough cases, and you have said it easy. Any questions from the comments from the other panelists, speakers?
No, I just want to, congratulate Amar on the beautiful. I've seen so many Yamane techniques, but the way you demonstrated it was phenomenal. Hats off. You're always an inspiration to all of us. Thank you, Amar.
Yeah, Nivian and Manoj, you'd like to say a few words?
Yes, sir. Excellent videos. Always there's a take-home message, and even the way how he separated the CTR ring from the IOL. There was no hurry, and to gently cut so that there's no traction at the vitreous base that can lead on to RDs later. So every step was carefully done in removing different stages. I think excellent, sir. Thanks.
I think the one important message from Amar surgery is that don't lose your cool anywhere, and be steady always, and don't lose your cool because there's always something which you can do better. And use of this the instruments which you can hold the IOL haptic or the IOL itself or the CTR for that matter, you're able to beautifully separate it all through very small incisions and very minimally invasive surgery. Fantastic results. And Amar, hats off to you, Amar. And
I just want to say something to all the delegates who are watching, Mohan.
Yes.
Is those who want to move into this in a better way, remember one thing, you need more haptic exercise. So if you have a large eye, more than 11 millimeters, I suggest making a small iridectomy in the area of the scleral flaps.
Yes.
So you can come even 0.5 millimeter anteriorly. You will have enough haptic exercise that lens will never move and it is extremely stable. The second point is keep it in mind at the end of the surgery to put in some air, see if there's optic capture. If air is there, if optic capture immediately occurs, you're in trouble. So immediately do a photothropoplasty. You can learn this technique because it's so simple to do. If the air injection doesn't produce an optic capture, it will get a post-operatively optic capture, so you are safe. So 2 tips. 1, do the peripheral iridectomy. 2, learn single pass photothropoplasty. You see your results change even better.
Absolutely. I think you hit the nail on the head. And it's important because when you go anteriorly, the possibility of optic capture is little more.
Yes.
So you need to keep that in the mind at the end of surgery, probably decide whether you want to do a SFT or not. So we go on to the third speaker, Dr. Sujata Mohan, who again doesn't require any introduction. Very versatile, cataract, cornea, refractive, glaucoma, except probably the retina, oculoplasty. She has done everything. And a very, very good surgeon, very good speaker. And she's going to talk to us on how to manage the dislocated IOLs without explanting them, by suturing them or gluing them or whatever it is, dislocated IOLs fixation techniques.
Thank you, Dr. Mohan and the scientific committee for giving me this opportunity. Before I start, I think I should confess that all these new techniques that I've learned is from Amar. Amar has been a great source of inspiration for me. And I started glued IOLs only after watching his videos. Thank you, Amar. So I'm going to show you 3 cases where we're doing an ab interno fixation of the dislocated IOL with 2 approaches. A 70-year-old male with a phaco foldable done 15 years back had a 6x6 vision. There was no history of toma, but he complained of shaky vision, which is oscillopsia. And the only thing was that he had a pseudo exfoliation. You can see when his eyes are moving, the lens is also moving. So there is a definite zonulopathy with a lot of zonules absent. That's why it is moving so much. So we decided to go ahead and do an ab-internal fixation, prepared the eye for a glued IOL. I placed a trocar cannula posteriorly. We can do an AC maintainer as well, but in this case, I did a posterior cannula. And see how easily the lens is coming out, because it's almost all the zonules are absent. So while you're doing this, it's very important that to make sure that it doesn't drop into the vitreous. So gently you try to bring it out and keep it on top of the iris before you do any manipulation. Here I'm trying to remove the capsular bag. I tried it with cystitome. Now I'm using a vitrectomy cutter to remove the capsular bag. It's important that you free all the capsular additions before you do a glued IOL. So I'm trying to remove as much of the posterior capsule as possible. And now using the handshake technique, I've exteriorized one of the haptics. At the same time, holding on to the rest of the lens using the Y fork. And then again, once this is exteriorized, you can see the same handshake technique being used for exteriorizing the other haptic as well. And then there was no vitreous disturbance, but I removed the rest of the cortex using the vitrector, tucked into Shadid's pockets, as described by the Amar very beautifully. Did a very minimal anti-vitrectomy just to make sure there's no vitreous, and then constricted the pupil, and the case was done. So you can see the flaps are being glued. That's a great advantage, and I'm all for glued IOL, because I did try Yamani. I'm really more satisfied with glued, but I think the whole world is talking about Yamani. I don't know why, because personally I feel this is really good. So you can see while you're moving, even the eye is moving, the IOL is well fixated. The patient regained a 6 vision without the opsilopsia and was very happy. So now I'm coming to a very similar case of a 70-year-old female, of a male with a dislocated IOL back complex. But this time this was a single piece lens, and he also had a pseudo exfoliation. You can see that, you can see again the lens is moving, and you can see the haptic and the pupillary area. So, so what I'm going to do in this is I'm planning to do a Hoffman's pockets. Hoffman's pockets are created corneally, and then you create a scleral pocket going under the conjunctiva, and then through the roof of the pocket you introduce a 26 gauge needle, and you retrieve the Prolene suture by docking onto the 26 gauge needle, both superiorly and inferiorly. And once you get both the haptics, you can retrieve the sutures and go ahead with the tying the sutures. Here you can see that I'm making two clear corneal incisions about 300 microns deep, and I'm creating a pocket. Sometimes there can be quite a lot of bleeding. That's the only problem with this procedure. Just check to make sure that you have enough of the pockets, making 2 side port incisions. And then now 26 gauge needle is going through the pocket, and it's going under the haptic of the lens, and it's retrieved. Again, the second portion of the needle is now going through the side port, and then being again docked onto the needle, and it's pulled out. So now one side, the loop is inside, and you can see the lens moving nicely. And you can retrieve the sutures from under the pocket and keep it aside before you tighten it, because you need to make sure it is in the center. You keep it aside, and then you move on to the other side and do the same. So here again, you can see now it's going, you can see more clearly that, see the 26 gauge needle is docked, and the 10-0 polypropylene is inserted to that. It's railroaded, and the one above and one below the haptic. Like Dr. Malugan was saying, I think these polypropylene needles can actually degrade over time, and probably it's better to switch over to Gore-Tex in the future. You can see once you've titrated, made sure that the lens is in the center, you can go ahead and tighten it. Make sure you don't tighten too much towards one side, and then the case is over. So that this is a third case of a dislocated multi-piece IOL. So the patient has had a PCR, and the surgeon had put it just into the the superior portion. He has just hung it onto the PI, and so the patient was totally dislocated. It had come down, so it removed the lens from the iris, or from top of the iris. And again, here the handshake techniques helps a lot, because then On both sides, you're able to catch hold of the iris. Now I'm doing a minimal vitrectomy to remove all the capsular contents. And here, using the handshake technique, we can see that the haptic is being presented. So both sides, the haptic is retrieved. In this case, you can see that I've used an AC maintainer. And once you've retrieved it, just center the lens nicely. Just make sure, like Amar said, there's no pupillary capture. Don't over tuck the lens, because then you might land up in problems. So just tuck it enough, just enough, say about 2 to 3 millimeters. Inside 2 millimeters should be fine. And then inject air. I always inject air just to make sure that we're not having any pupillary capture, and also to make sure the pupil is round and it's not tucked in anywhere. And then the case is completed. So all 3 cases were managed ab interno with totally this thing. So I'm just going to show you, since I have time. I have a case who had a 45-year-old female, AC phakic IOL done 15 years back. She had trauma with a tennis ball, sudden drop in vision, dislocated IOL, a phakic IOL with a Vitreous syndrome. So this case, one part of it was at least already disenclaved, as you can see. So the other portion, I gently disenclaved from the iris, rotated the lens, and this was a rigid lens done about 15-20 years back, the Vitreous model, and removed the lens and sutured the opening. Went ahead with the phaco because this patient had already developed cataract also. But I think this was not due to the trauma, but she developed a cataract, must have developed a cataract over a period of time, and she landed up with us because of the trauma and sudden drop in vision. And unfortunately, during this time, she has also had a Vitreous syndrome, and the pupils were not going down even after injecting pilocarpine. So, so you can see that the case has gone on very well, very nicely. And injecting, because she had a very high myopia, somewhere around -3, and had to put a multi-piece IOL. So I tried to see whether I can do an SFT for this patient. But the iris was quite stuck and very fibrous. So I decided to do an iris encirclage. So this is probably my first case. And if I do it next time, I may alter it a little bit in that sense that probably I will put more, tuck in more number of times. So what I've done is I've done it a little bit farther apart, and the superior portion where I've sutured actually was very fibrosed, and it was every time I was trying to tuck it in, it was tearing. So that's the reason why in one area alone I was not able to take multiple sutures, but went all around. So it's important that you take multiple side port incision to facilitate this. And once it is done, you can just tighten it and tighten as much as possible. You can see that one area alone I was not able to tighten properly because of this cheese wiring. So, but ultimately she did well, and she said after a long time, you can see that the pupils are pretty normal except for the superior portion. What her this thing was feedback was, she said after a long time I'm able to go out in the sunlight without wearing sunglasses, because this, I think she's had the Vitreous during the primary procedure itself. So I'd like to thank once more for the great opportunity. Thank you.
Thank you, Sujata, for a very, very comprehensive, I think, talk, and he covered everything, sutured the dislocated IOLs or subluxated lenses with the bag, without the bag, and glued IOL. It's a what you call combination of all techniques, and I was very impressed with the purse-string suture of that, especially with Vitreous syndrome. So I just want to ask you a quick question, okay, to Amar, and then come back to you. Amar, what do you do when you have a dislocated single piece or subluxated single piece IOL with the bag? Do you do a suturing like this way Sujata showed, or you will explant it and put a glued IOL?
If I have a single piece non-foldable IOL, I will definitely glue it in the same lens. If it's a non-foldable, one piece non-foldable IOL. Okay,
no,
like
I'm talking about.
If you talk of, I'm coming to it. If you are talking of a subluxated one piece foldable IOL, I will always pull it out. The reason is very simple. If you take all these videos of these patients with a high-speed camera, you know, or a slow-mo camera, which we call them, then you will notice the lens moves. So I will explant. You can cut it and explant, call is yours, or make a skeleton engineer, and I'll fix it a glued IOL. On Sujata, your purse string suture, I'll tell you one simple trick. When you end it, you can do a 4th row, then you don't need to do again and again, second and third pass.
Yeah, yeah.
You understand? Normally you do a 3-2-2, but in this, I have done, you can do an encirclage, 4th row pupiloplasty. The same principle.
Amar, and this was done about 4 years back. So
No, I'm just telling you a simple trick for the future. When you do the next purse string, you can do it as a 4th row later on, so that you end it with a 4th row. You don't have to go in and again do it.
Again and do it. So
that's exactly what I wanted to say. Because there's one thing I learned from you, that you can do even at this point, you can do an SFT and use it instead of, from outside you trying
absolutely. The indications are SFT, because many people think that we can leave the traumatic mydriasis like that, but it produces a lot of glare for the patients and a lot of decrease in the vision.
And also closed angle glaucoma.
Yes, and also closed angle glaucoma. Everything is taken care by pulling the iris. It works like a long-term myotic, So that is the advantage of this. And Sujata, what you would have done, because you have a lot of experience with the single-piece lenses being sutured to the scleral wall, and we have got fairly long-term good studies. Amar, I just want to ask you, because by removing that lens and putting a glue dye, it's more of a complete radical surgery, because you are explanting, you have to extend the incision, and
see, Mohan, you don't have to extend the incision, number one, because you can just cut the lens and bring it out.
Yes,
it's very simple. So that's one step. Second step is, let's look at it. It is not radical, but even if you want to extend it, let's say, even if I make a scleral tunnel incision and pull it out, it's much easier. But look at it, the long-term results, Mohan. I showed you, that's why I showed you a patient which has got an Ahmed segment. It has got an endocapsular ring. It has got a sutured IOL inside. And still that lens after some years are sinking inside. So I have done a lot of these sutured IOLs and I'm not happy now with it. Whereas you see post-operatively, when you see the glued IOL, the guy is happy. So even if it takes me that couple of minutes extra, even if I'm putting a one-piece foldable IOL, I will take it out and replace it with a glued IOL.
Absolutely.
I just have one point. I may do the same thing, but I may not use this 10-0 polypropylene. I may go in for a Gore-Tex, what Dr. Malugin showed, because now we know that these polypropylenes can degrade. So maybe 5 years, 10 years, you really don't know, because of the constant movement, it may degrade. And maybe using a Gore-Tex would be a better choice. I mean, even go ahead with the Hoffman's pockets, do everything the same way, but use a Gore-Tex suture.
Okay. The Hoffman's pockets, I want you to enlarge on that particular enlighten us. Hoffman's pockets, we have done courses with Richard Hoffman in the AO as well as ACRS. And it's a very, very useful technique. You don't have to open the conjunctiva. So what is the particular advantage of Hoffman's for the benefit of the delegates?
Hoffman's pockets, you don't need the glue first, and it can be done by anybody. Only thing is, the technique is a little bit tricky, because either you can make a very superficial pocket or you can go too deep. So you just have to tighten the pocket. Maybe you can use a depth knife, say about 350 microns, and start the dissection from that place. The second point is, like, there can be quite a lot of bleeding. So that is one thing which is quite disturbing. In some patients, they can bleed quite a lot. So that can be quite disturbing, but even then it stops in a while. And the one advantage is, once if it bleeds, it sticks better, because there's some autologous glue in that. And it's a very simple technique. There are 2 points, always you have to check the pockets to make sure how large it is. While you're putting the 26 gauge needle through it, you make sure that you're going through the pocket instead of outside. Then the whole process is lost. If you're not able to retrieve the sutures from inside the pocket, then you'll have to redo the whole procedure again. So you have to make sure that your entry is through the pocket. So it's important you check with your 26 gauge, your side port instrument or something that
it's got a learning curve, but it really works wonderfully well.
I wouldn't say the learning curve is bad, but a little attention to detail is very important. That's
absolutely. All. Amar, I just want to, before we go on to Dr. Manoj Khatri, I want to suppose there is a single piece PMMA that is rigid IOL, okay, which is subluxated or dislocated. So do you fix it up with glue?
Yeah, I fix it with glue, because only thing is, you should know the handshake technique very well. That's all. Your handshake technique has to be bang accurate, because remember one thing, in a 3-piece, nothing will happen. But in a 1-piece, it can break. But be careful that you catch the tip of the haptic and externalize. Don't catch it somewhere in the middle. Somewhere, if you bring it somewhere in the middle, in a 3-piece, if you bring it out, okay, nothing will happen. but this might break. So I'm very particular when you're doing a single piece, non-foldable IOL, I will not explant. The same lens I will fix. I've also got cases, Mohan, which have been put in a PC IOL in the AC. So what I do is I just transfer that back down, PC IOL into the PC, glue it inside, and if it needs a PDEC and SFT at the same time, finish all in one shot.
Fantastic.
Just one last this thing on adding on to what Amar said. When you do a PMMA, you have to rotate it. You have to make sure there is no tension on the haptic optic junction, because because it's rigid, it will definitely break. So that is one area you have to keep rotating it as you pull it out. So that's a very important trick that you have to learn.
Another important message is catching the tip and externalize, and take a little more precautions while doing a single piece lens, because that is a very fragile. There's a possibility of breakage. If it's breakage, then you have lost the battle. You have to explant the lens and probably go in for a multi-piece glued IOL for that matter. So we'll go on to Dr. Manoj Khatri and come back for some more questions. Manoj Khatri.
Mohan, just a second. There's some question here.
Yes.
Dr. Preeti Jain, in video, we don't need to create flaps. We have to enter with 26 gauge needle as trocar. Is it so? That's one question. And I've not understood the question because I did show a flaps creation. So the answer, Dr. Preeti Jain, is that there is you should need to make your flaps when you're doing the glued IOL. And a question is there for Sujata Mohan from Rajesh Ganesuni. Excellent fixation, Dr. Sujata, for 3-piece IOL. What is your procedure of choice if the IOL was a single piece IOL? Sujata?
I think we answered that question. No, we said if it's a single piece PMMA, you can definitely do a glued IOL. Only thing, care has to be taken about like the 2 points: haptic optic junction and catching hold of the tip, and knowing your how to present the tip to your this thing. That handshake technique is very important.
But the most important thing is everything should be done with smaller incision, very minimally invasive surgery. The results are much better. The post-operatively, the eyes are quieter, inflammation is less. And I think hats off to Amar for inventing this technique. And we'll go on to Dr. Manoj Khatri. As you know, Manoj Khatri is a very prolific vitreoretinal surgeon. And he's, in my opinion, one of the fastest vitreoretinal surgeons in India, and very good, very effective as well, a very good speaker and very good researcher, a lot of papers to his credit. Manoj will be talking to us because dropped IOLs is a very major problem. If you have an IOL which is subluxated or in the pupillary area, you can probably fix it up the way Amar or Sujata was telling. But if you have a dropped IOL into the vitreous cavity, obviously you have to remove it. Either you can remove or fix up. If it is the same IOL, we can fix it up by means of glue or some other technique. Manoj is going to talk to us now. Manoj, you can share your screen.
Yes, sir. Is my screen visible?
Yes.
Thank you very much, sir, for the kind introduction, and also inviting once again for your very, valuable course and very popular course, as Amar sir already said, not only in India, abroad as well. Sharing the dais with all these luminaries is always a pleasure, and also make us humble and try to learn different things, and keep us on our toes. Coming to management of dropped IOLs, I will be sticking my talk only to dropped IOLs. A couple of pointers which we have learned and we still learning, though it's one of the rare complications, but it has to be handled in a very proper way. No financial interest in my talk, but a couple of things before we start thinking or talking about this is, first thing is, all of us, whether you do cataract, you do retina, whatever it is, you have to be very, very well versed with something called as a bimanual vitrectomy. That means what the importance Amar sir highlighted, your both hands had to work together in conjunction, whether you are trying to take out the IOL, you are trying to rotate the IOL, you are trying to maneuver anything into the anterior chamber per se. Both the things, sorry, 1 minute. So both your hands, right and left hand, has to work in coordination, in sync, I will say. So once you have a problem, as you can see here, there is a large PC tear. Don't try to do anything. Try to use a bimanual vitrectomy system in which you separate the cutter as well as the infusion. So once you do that, one is your infusion is much more controlled. There is a good tamponade on the vitreous, and you have a very controlled environment to doing the vitrectomy. Make sure that your vitrectomy probe, the tip of the vitrectomy cutter faces towards the vitreous and not towards the pupillary side or towards the towards the corneal endothelium. So in this, you are going to cut very, going to cause very less damage on the vitreous face, and also try to be always in the center. This is a very important point. Don't try to be at the edge of the side port. Try to be in the center of the pupillary axis, and never try to do this through a main port. Always suture your main port and secure it. So this is one tip which I wanted to share. All of us, whichever segment you operate, apart from oculoplasty, we have to be very, very well versed with your machine, with your bimanual vitrectomy system. Don't try to make these mistakes. As Amar sir rightly pointed out, putting the wrong lens in wrong place. Putting the lenses in anterior chamber, it's okay, but it's olden technique. Nowadays, we don't do it. And then putting one more lens which has gone behind. When you have a complication, either you can manage on your own or call your VR colleagues, and they will help you out. They will be able to help you out. But never try to put, try to avoid this kind of complications. As you can see in this case, we explanted 3 IOLs from a single eye. So never ever do these things. The more damage you cause to the iatrogenic damage you cause to the eye, the poorer are the outcomes. So never do that. Sometimes even in experienced hands, when you have long OT list and all, sometimes you become careless. So this is one thing which I have learned over a period of time watching masters also. Speed doesn't matter much, but your carelessness attitude or your carelessness at any stage of the surgery, as you can see here during this procedure, the surgeon not even realized that there is a PCR and the lens has gone behind. Again, you can take out this lens at this particular sitting, but the important point take home message is just avoid your carelessness attitude. Always be very, very careful. As you can see here, this again, one more IOL has gone into the vitreous cavity, which can be easily avoided. And when you have a compromised anatomy here, your surgical maneuvers have to be more than perfect. So what everyone has to learn now is what we are advocating, and all the masters are advocating. Even Abhay Vasavada sir, who popularized this technique, is something called as a vitrectomy, which you want to do in the anterior chamber. That means we want to take out the vitreous from the anterior chamber, but you use a pars plana approach. So as what you can see here, we have put though this was a secondary stage procedure, but there is a pars plana infusion here. This is a 25 gauge vitrectomy system on Alcon. But nowadays, good 23 and 25 gauge vitrectomy systems are available with all the machines. So you don't have to pick and choose about the machine. But what we have to learn here is when you're trying to cut even the vitreous from the anterior chamber, rather than going from the limbal route, which is not that control, you go from the pars plana route. And this can be just 2-port incision. We don't have to put the 3rd port. The 3rd port, normally the VR surgeons use as a light source. So you don't have to do that. As what we are doing here is there are 2 ports. What you see here, this is an infusion port, and this is a port for your vitreous cutter. We have taken this into high zoom. That's what is not so visible, just to show you the importance of how controlled atmosphere is there when you are cutting the vitreous from the back. So there are 3 major advantages. One is you are not causing any traction on the vitreous face and also on the vitreous base. When you take your cutter from behind, you can come into any zone. You can be at the pupillary edge. You can be in the center. So you are cutting the vitreous at a much in a safer manner, and also you can clean up all the wounds quite thoroughly. So these are the major advantages. At any stage, whenever you are in doubt, you can always stain the vitreous with diluted translone acetonide to help you to aid, to assist things further. As what you see here, we are gone with a high-speed cut rate with the lower suction here, and the infusion is there. You can do handshake technique or whichever technique you want to apply here. The only point I wanted to add, as been rightly pointed out by Sujata madam and Amar sir, whenever you're doing a handshake technique, make sure the pressure in your right hand and left hand, whenever you're trying to rotate these IOLs or CTR rings, is equal. The problem occurs when the counter pressure is not equal in your both hands. That time only you will be breaking this haptics, and this is by experience. We have done these mistakes. So always advise that the counter pressure in your right hand and the left hand is the trick here. So make sure that you don't repeat that. And then what you see here, all the vitreous is cut in a very clear manner, and then you can take it forward. So this is what I wanted to say, that rather doing an anterior approach, that is a limbal approach, all of us here, anterior segment surgeon or a posterior segment surgeon, whichever way you are operating, should not hesitate to shift your horizon. If you have a problem which needs an anterior vitrectomy, rather than doing a limbal approach, go to a pars planar zone. Most of the glued IOL surgeons who are doing it, they are already using an infusion cannula for the same, and you can use one more port so that the cutter is in much more secured environment. Couple of points where to take out these IOLs. Yes, we need to take out in different situations. Nowadays, we don't do it. As Amar sir rightly pointed out, we try to fix this IOL. But this kind of a hydrophilic and hydrophobic, both IOLs, they are quite slippery. In this case, what you can see here, never attempt to fish out these IOLs. The primary surgeon tried to do that, but I always advise don't do that. Once the IOL has gone back, let it go back. Complications can occur in best of hands. You don't have to worry about it. Still, if all the steps are taken correctly and the procedure has been done well, this patient will have a 6/6 vision. So the important thing here is not to touch this IOLs till the time you get a good posterior vitreous detachment and debulking of the vitreous. Once you do that, these IOLs are very slippery, as has been highlighted by Dr. Ashwin. Either you can use the suction from the machine, but it is little tricky. You need to be little well versed for using the posterior segment instruments, or always catch hold of the optic haptic junction. Never try to attempt to catch these IOLs at any other place. This optic haptic junction give you some kind of a stability, so try to catch these IOLs at the optic haptic junction, and then you can take it out quite easily. Rigid IOLs are very tricky to take it out from the eye. As in this patient, what you can see here, the rigid IOL has fallen, and also not fallen clearly on the surface of retina. It is lying vertical. So again, there is a danger here. The moment you cause any kind of undue traction on the surface of retina, is going to go for major breaks over the surface of retina, and you might end up with a retinal detachment, which can be iatrogenic. So we have to be very, very careful. Always try to free these intraocular lenses, of any kind of vitreous which is available, which is present there, and then only try to touch this IOL. If the IOL falls back on the surface of retina, it doesn't matter. Let it fall back. It will always fall back slowly. But important thing is here is, even if you are removing CTR or IOL, one is your handshake technique has to be good. The second important thing is removal of CTRs is very tricky. It is not as easy as removal of IOLs. Intraocular lenses can be removed in an easy manner. But whenever you have a CTR, either which is there in the ciliary sulcus or ciliary body area or gone back, it's very tricky. It is very, very slippery. So most often or not, you will have to use a handshake technique, and never attempt to take these structures out of the eye unless and until there is a good amount of vitreous which has been separated out. So that means a good vitrectomy plays a very vital role. Couple of other iatrogenic things we should avoid. This primary surgeon was overzealous and stained the vitreous cavity as well. So it is very tricky for us to visualize during this kind of a procedure. Even for a VR surgeon, the view will not be very great. So try to avoid, as I am catching it at optic haptic junction, which is a tip I gave it to you. You can do that. Fairly easy technique, and then also try to maneuver this lenses. Very challenging situations when you have either retinal detachment or a vitreous hemorrhage associated with a dropped IOL. We need to be little patient here. Try to do again, the importance here is induction of posterior vitreous detachment, then only touch these IOLs and take them out. This was a hybrid vitrectomy. That means one port was 20 gauge. This was slightly older video, so just wanted to highlight the importance of managing these lenses, or even try to take these lenses out of the eye unless and until there is a good amount of vitreous which has been taken out. One more case where we trying to do a posterior vitreous detachment in a very hazy cornea. This was a misty cornea, but we cannot do much, more than what we can decompress the corneal epithelium. So try to preserve even corneal epithelium. But the trick here is try to do what we call as multi-quadrant PVD induction. That means don't try to do PVD induction only in one zone. You can go 1 clock hour by 1 clock hour as you complete your capsular axis the same way, and then only catch these IOLs at the optic haptic junction and try to take it out. Pediatric cases are also tricky. Where this was a planned PCCC case where you can see such a nicely done PCCC, but again the surgeon was not very careful and injected the IOL into the vitreous cavity. So don't be show a carelessness attitude. Be little careful. Do all these maneuvers little slowly and with good visualization. Always we have seen either you are little careless or the visualization is poor. That means you're not able to focus well. So unless and until you are visualizing it well, we cannot do these procedures to the T what has to be done. One of my last videos in which, as I said, endocapsular ring or any kind of other kind of segment, this was a patient who had a reticent implant which dislocated inside. very, very tricky case. We need to break this into sometimes into little segments, or whenever we are trying to remove it, you can see here there is so much of slippage here. The reticent was not getting caught at all. So we need to be a little patient not to cause any damage to the underlying surface of the retina, and try to take these implants with utmost caution. One of my last videos with Dr. Sujata, always a pleasure talking, like not only talking, operating with her. She was, we had a patient who had a dropped lens. You know, the entire nucleus had been dropped with the first chop itself. There was no capsular support at all, what you can see here. So what we did was slightly reverse approach. We first did a glued IOL. As you can see here, she is doing a glued IOL, which has been done to the perfection. And even the lens was implanted. The lens was, even the haptics were externalized. Only the infusion cannula was there in place. And once she finishes her part of the surgery, even anterior vitrectomy was done to the to perfection. And then only we went ahead with vitrectomy after putting the trocar cannulas. And what you see here is the entire lens with the capsular bag, nucleus with a capsular bag, and we did a removal of this nucleus. And at the end of surgery, very nice, stable glued IOL. And this glued IOL is a game changer, I would say. So a lot of things we are learning. However, managing complications is not
Dr.
easy.
Manoj.
Yeah, finish. Careful assessment.
Say that. We have precised 18 minutes left, and I think we have.
No, we have one more speaker. I think we are going on time. Don't worry.
Thank you so much, sir. Thank you.
Thanks, Himai.
So careful assessment is very tricky and has to be done thoroughly. Planning of the surgery, understanding principles of management involved, and teamwork is the way to go forward. My acknowledgements here, right from Amar sir to Nivian, everyone. Thank you very much for a patient hearing.
Thank you, Manoj, for the very, very nice exhaustive talk on the dropped IOLs. It's very important that you manage it with appropriate and follow the protocols very correctly. And I know these hydrophilic lenses are a little tricky because they are very slippery, and you showed that in the thing. And we find that Ashwin Agarwal's beautiful technique of using a fruit needle and or the extrusion needle to just take it out, and with a very minimal passive section, I would say, bring it up, and it works wonderfully well.
Absolutely agree.
Yes, most of these IOLs have to be explanted, and probably we have to give alternative technique like a glued IOL. The glued IOL, as he rightly said, is so versatile. You can do the glued IOL in the beginning and have the glued IOL and go inside and remove the nucleus with the fragmentome, and you can play around with the glued IOL.
It has increased our confidence that, whatever complication happens, we are able to manage it quite successfully. So that is the confidence we have got.
Amar, you would like to have say something on this?
I think what Manoj has shown is just excellent. And there are some questions also.
Yeah.
One is, Manoj, in Dr. Preeti Jain is asking, in the video of Dr. Manoj, it appears he held the hole in the IOL, not the haptic optic junction. Can you answer that, Manoj?
Yeah, so we are trying to take a grasp. I just rushed the video due to paucity of time, but we have to catch it on the optic haptic junction only.
Another question which Dr. Preeti Jain is asking is, she's a beginner, so tips for handshake technique, how easily you do it. I think the answer, I'll ask Mohan to answer it. My tip is very simple. You need 2 glued IOL forceps. They are available, dime a dozen companies are making them, You can get a 25 gauge glued IOL forceps and use it. Mohan, basic idea, and Sujata, she wants to know, Preeti Jain wants to know some tips on mastering the handshake technique.
Very, very, very simple. Sujata will be able to answer, but very simple is that you need to be bimanual, very important, and try to hold and grasp, then re-grasp, and then come to the tip. So that is the main thing, and you have to, of course, Epsilon and many other companies are making this 25 gauge glued IOL forceps.
So, the one tip is you should have a micro forceps. The second thing is go to YouTube and watch Amar's videos repeatedly. You will be seeing so many of his videos. It's the easiest way to learn. No amount of talking about it is going to help. Amar is all the videos there. So it's the easiest way to learn.
Very nice. I think I hope we have answered Preeti's thing. And we go on to the last speaker in this very interesting session. I kept him in the last because Dr. Nivian, as you know, is like Dhoni, okay? And he's a fantastic, very dynamic, both anterior and posterior segment surgeon, very good innovator, and the genes cannot go wrong, Nivian, and you have done exceptionally well. And he's going to talk to us on iris claw lenses, which he does regularly, as well as these new innovation, the new kid on the block, the CMT Flex lenses. Nivian,
Thank you, sir.
you have 11 minutes to go.
Yes, sir. Thank you, sir. It's always a great pleasure and honor to be sharing the session with you and Amar, sir, because you have been my mentor and inspiration in most of the things that I do and the surgeries that I show. So the first half, I'm going to talk about the claw lenses. So for a lot of anterior segment surgeons who have complication, I think this is the easiest way out, and then mastering on to the glue diol. So the claw lenses were described by Wurst. He was inspired by the claws of the lobster, and that is how he came up with the design. It's a single piece lens with one material, and the fixation mechanism was how the iris tissue gets enclaved into the clips of the IOL lenses. So I'm just going to show you a small clipping of the lenses. So these are the lenses. As you can see, there's a small wedge there. So within this space is where the iris tissue is getting enclaved. And you can see the one more thing is the use of the forceps. We use something for this broad that's called the Shepherd's forceps, because you need a good grip of the lenses. We cannot use a regular IOL forceps because that tends to slip the lens. And many people will ask, they're not able to enclave properly because the grip is not good. So these two instruments are very important. So the first scenario is an old aphakic patient. We being VR surgeon, I prefer the 23 gauge trocar, but I think this was before the invention of the AC trocar maintained by Amar Agarwal sir. So that can also be used by anterior segment surgeons. Since these are rigid lenses, that is why we're making a scleral tunnel. So that is another difference between all the glue diol surgeries that we saw today. I always prefer tricot. I think sir has already emphasized the important, because if you can say stain and see the vitreous so clearly, because for any secondary IOL procedure, I think everybody will agree, a good vitrectomy is a very, very key indicator, because it reduces post-op CME, reduces the risk of endophthalmitis, and also any decentration of the IOL. So once the vitrectomy is being done, so the claw lenses are placed, hold it firmly, take it under the iris and push your right hand up and the left hand down, and it is clipped. I just slow it down to show. You can see my other hand is already in position. So this is another tip for people who want to start. I know where I'm going to clip it, in the mid periphery of the iris, not too anterior, not too posterior. And then we clip it. This was another case post silicone oil aphakia in an RD patient. So here again, you can see the claw lens being taken inside, and then a slight depression is enough. In very ultra slow motion, my first hand is already waiting. As I told you, the mid periphery is very, very key here. That avoids the ovalization of the pupil. So taking the lens underneath, lifting up your left hand, and then pressing your right hand. So both have to work in congestion. As you can see, just a mild force. There you go. And then you can see the dimple there on the iris. So that shows that it is enclaved, and you can get these round pupils also. One of the contradictions, they said glaucoma, but as such, the IOL doesn't induce glaucoma because of the pigment dispersion. So this was a case of a combined trab in an aphakic patient who was, so the glaucoma surgeon did the superior trab. Said this again was inspired by the vertical glued IOLs that sir showed. So we shifted to the temporal section after the trab was done superiorly. As you can see, a new, and these rigid irises also can sometimes make it difficult for fixing these lenses. So here the third trick I would show you is to grasp these lenses, because we should not damage the iris or cause any bleeding. So fill in good viscoelastics. You can use your iris, the second instrument, as you can see here, maneuver the iris carefully instead of pushing it and physically damaging. Just use your second instrument to move the iris and then take it gently inside. So this way it causes less damage to the iris. Only in this particular case, because it was a known case of a glaucoma, we did a peripheral irisectomy. Otherwise, routinely for the claw lenses, we do not do a PI. So this was a known case that we did a PI with the cutter. This is the easiest for us. So there are complications related to the procedure. You can get an irregular pupil. You can have iris bleeding. That is, if you go too much to the roots of the iris, or tearing of the iris if you use too much of force or pressure. Non-clipping and breakage of these haptics can also take place. So there are already also other alternatives like the glue diol, as madam showed, also the scleral fixated IOLs. So we did a study comparing the two, and we found out the post-op vision was less, but there was a slight increase in inflammation in the iris claw group. I think we did a study with Amar Agarwal sir also. The pseudo-phacodonosis was found slightly more in these claw lenses as compared to, as he said, the stability of the glue diols were definitely better. But we for an anterior segment surgeon, this is definitely an alternative. You can see immediate post-op pictures and late post-op pictures, also well-round pupil, and you can see the dimple on the mid-periphery of the iris. So it is a relatively easy procedure to do also. So now moving on to the second half of the new innovation, the CMT Flex IOL for the treatment of aphakia. No financial interest. So this is the new CMT Flex IOL, which is a single piece hydrophilic lens with a specialized T-shaped haptic. So these T-shaped haptics, when brought out of the sclerostomy, opens up and prevents the lens from falling back inside, so that there is no requirement of suturing. So as you can see, this is a case of an aphakia that presented to us. But most important thing is, for any secondary IOL, the 0-180 degree marking is the key for the IOL stability and to prevent it. So we're using the Ashwin's glued IOL marker to mark the 0-180 degrees here. And we create a 2 by 2.5 scleral flaps on either side using the crescent blade. A partial thickness flap is created 1.5 millimeters away from the limbus. A sclerostomy is made using a 23 gauge needle. You can use the MBR blade also. So already Manoj has emphasized the adequate good vitrectomy. So the vitrectomy has been done. So just skip that part. So using the Prenerve T-Flex forceps through one sclerostomy, the IOL is going to be injected through a clear corneal 2.8 millimeter incision. As you can see, when it comes out, the T haptic comes out first. So you grasp it head on. So that is the best method to do. As you can see here, the head on grasping. You can also catch the neck, because these are hydrophilic materials, they are forgiving. At this time, we do not pull out the lens. We inject the rest of the lens and leave the second trailing haptic at the wound or over the iris. So once the lens is injected fully, and then carefully, the T junction, you can see there will be a pop of the T that comes out through the sclerostomy, and it opens up, and then we leave it. So this specially designed T-shaped haptics is what prevents the lens from falling back inside. Just a small animation clip. This can be loaded through any routine foldable injector cartridge, just making sure that the T junction comes out first to make it easier to grasp. So once it is loaded, as you can see, injected through a clear corneal incision. Initially, we're doing like this, so you have this 90 degrees of pulling, or you can go either opposite side, so it makes it easier to do. Again, the importance of handshake technique, I think it is emphasized enough. So you have to use the handshake technique to grasp what we call the bridge of these lenses, and then transfer it to the other hand. As you can see, again, try to hold it to the head on. Make sure you get a firm grip. And once you get the firm grip, gently remove it through the other side. So you can see the pop of the T-shaped haptics on the other side. And that is almost the end of the surgery. So we do not require any suturing here. So now you can see these T-shaped haptics firmly snug there. So now we close the flaps and this thing using the fibrin glue. So these are some of the immediate post-op day one pictures. You can see a few DUM folds because of the day one. And then on 1 month post-op, you can see how round centered pupil and very good conjunctival closure. And we also done studies on UBM to know the position of the lens and whether it causes any friction when the pupils dilate. And also some OCT pictures through the sclera to see the long-term effective of these things under the scleral bed. So we also have a recent publication in the JCRS about this being a new innovative technique for the treatment of aphakic patients. So thank you once again, Evers, and big thanks to Mohan Rajan sir for always being mentor and inspiring me, and Amar sir for always giving me confidence and helping me out, and Manoj, through whom I've learned a lot during my fellowship days, and Sujata ma'am for being. Thank you, sir.
Thank you, Nivian. I think you have summed up the session very nicely. You have initially talked about the iris claw lenses, and then your new innovation, the CMT Flex lens. I just have a couple of questions.
Can I ask one question to
Madam, sorry to intervene. If you go in the question and answer section, there are a couple of questions from the audience which are there.
Okay. Absolutely, we are going to answer that.
Please.
Thank you, sir. Answer that.
Thank you, sir.
Amar, we can just find out the questions.
Mohan, all answered, Mohan.
All answered. We are all answered that.
Only one last question for Dr. Nivian. Good tucking demonstration for iris claw. Is it not mandatory to do a PI for iris claw lenses to prevent pupillary block?
Not necessary.
So not actually necessary. And our group of studies and publications, we have not done it as a routine, but other people practice it. The other indications for this glaucoma can be because of the excess use of viscoelastics. So the careful removal of all the viscoelastics and doing a good vitrectomy. Most of the times they leave some amount of vitreous, so that can also cause the pupillary block in these lenses. And tucking it in the mid periphery, because when you go too posteriorly, the lens comes closer to the iris diaphragm, and that can cause the block. So we don't do it as a routine.
Maybe just one question. That CT lens which you're using, what is the diameter, the measurement of that haptic which is you're pulling out?
The head.
The haptic, this thing is 1.4 meters, ma'am. The overall diameter of the lens is 14.
No, the T-shaped area which is coming out now, which is what is the diameter of that? Measurement of that?
1.4.
1.4 millimeters.
Yes, ma'am.
So, because see, you're going through the same thing for using a microforceps. Don't you think it will enlarge the incision too much when you pull it out? There's a chance it can slip back.
Sclera will just slightly expand because we use the same 23 gauge forceps only, ma'am. Or you can also use the 25 gauge forceps. But sometimes the 25 gauge forceps doesn't give a good grip of these lenses because hydrophilic they're a little thick. For the gluediol, the haptics are thin, so you can use a 25 gauge forceps also. But for these, because the material is thick, it may not give a good grasp. So sometimes it tends to slip when you come out through the sclerostomy.
No, I have two questions for you, Nivian. One is regarding the iris claw lenses. Because the iris claw are relatively a blind technique because you do not, how do you know that you have enclaved it properly before you leave the lenses there? Okay.
So one simple trick is after doing on one side, you can give a mild tuck and see, sir. So when you see the iris moving, you know it is clipped. Otherwise, sometimes the lens tends to come up. But too much of force should not be there because the roots can be injured and then bleeding can come. So just a mild movement. But most times you can also look for the dimple in the iris. So once some amount of tissue gets enclaved, there will be a small dimple in the iris also. So these are the two signs that
important message. Second thing, yes, regarding the CMT flex lens, as Sujata asked, because when you try to pull that head 1.4 millimeter through the sclerostomy, what is the size of the sclerostomy? Number one, do you have one common size of the lens for all the people? Because there's no way you can adjust this lens like the glued IOL. You can tuck on one side, as we discussed during Amar's talk as well, that in glued IOL you can actually tuck or untuck on one. And here it's just fixed there. Okay?
Yes, sir.
Just fixed. So, Amar, I want your take on this.
Yeah, that's a good point, Mohan. You see, what Nivian, what he's trying to tell you is that, see, suppose I'm putting a microcornea IOL, let's say, in a microcornea patient who's got a white to white of 8 millimeters.
Yes.
The glued IOL, I only need the optic. The haptic is externalized outside. So all I have to do is cut the haptic. But I need only 6 millimeter eye. When you have a fixed 14 millimeter lens, yes, which is fixed white to white, then you cannot adjust. That's what Mohan's point is.
Yes, absolutely.
Correct, sir.
Suppose you have a small eye, and if you have a larger eye, then what happens? Then that haptic will not come out.
Yes, sir. Right now, we are having it only for the routine eyes. If you have a high myope or a hypermetrope, only thing in hypermetrope is instead of 1.5 millimeters, you can go 2.5 millimeter sclerostomy. So that can help. But I think that's a good point. Right
one
now,
more point, Nivian, is it's a one-piece foldable IOL, I understand, correct? So yes, that's one trick which I feel is a problem because you need a 3-piece lens to go into the sulcus area. Keep that fact in mind.
Yes, sir.
See, now what is happening is you're putting a one-piece haptic throughout under the iris. So you might land up with transillumination defects. Just keep this fact in mind so that tomorrow when you are...
UGH syndrome may be a
yes, all these problems will start.
Constantly, every time the pupil goes up and down, it's rubbing on the surface of the lens. And you can have pigment release as well. But these are all long-term things, but definitely a good innovation. We have to keep that in mind. How many
just one more small point. There was a video by Jacob, It's over. Time is over. Okay.
Another 2 minutes you will take, Himai?
I'm extremely sorry, sir. Okay. We can just have 30 more seconds to wind up.
Yeah. One last
session. All the participants are already waiting.
Yes. You have seen the video by Susan Jacob, where she's used for scleral fixation. Why can't you do at the edge, like Amar said, why can't you put a multi-piece edge so that, it will be more smoother? The whole technique is so easy, but if you have a multi-piece haptic, it may be much better.
Sure, ma'am.
How will it stay on the sclera? How will it stay on the sclera, multi-piece? Okay, we'll close down the session. since we are running out of time, thank you very much, all the speakers. It's really a fantastic course. It's always a pleasure to conduct the course with all you guys. And we have had fantastic take-home messages, lovely videos, great faculty. See you again.
So I would like
so
to
very
take
much.
this-
Thank you.
Mike.
Thank you
I'd
so
like to
much.
take this opportunity to thank Dr. Mohan and a special mention to our international speaker, Dr. Boris. He stayed with us till the end of the session. Thank you so much for sharing your valuable time on the virtual platform. I hope you had a good time with your discussions. Thank you so much, doctors.
Thank you, Boris, for that.